So the first question, I'm going to read it from the back, okay, just to keep me focused, right? Which nurse intervention is a priority? There's a word there. There's two words. There's intervention and a priority. A nurse in the emergency department is caring for a client with severe muscle weakness. Those are my buzzwords. Severe muscle weakness of the right leg. So I've underlined two keywords in that question. Severe muscle weakness. And then I have to do some intervention. What do you guys think should be the right answer, right? Severe muscle weakness, and you have to intervene. That's all. I've not told you what kind of problem the patient is having, but this is enough, right? Connect these two dots. Muscle weakness and an intervention. I can tell you, to answer this question, you have to pick an answer choice that indicate intervention. If the answer choice is not an intervention, it's a wrong answer. That is your number one. If you pick an answer choice that does not indicate an intervention, then it's going to be wrong. So what do you guys think? Which of these four answers indicate an intervention? I've already made a diagnosis that I have muscle weakness. I should not pick a diagnostic procedure. So A, electromyography is a diagnostic. It's giving me a diagnostic idea, telling me more about the muscle weakness, right? I already know patient has muscle weakness. There's nothing wrong with it anymore. CK, creatine kinase, is a protein in the muscle. It's also giving me more diagnosis. I said intervene. So you have two interventions. You give them NSAID for the pain, weakness, or the range of motion. I did not say the patient has pain. There's no pain here. I said weakness. Therefore, NSAID is not going to work. This is how you answer question. You have to answer what they ask you, not what the answer choice try to portray to you. You see how we eliminate everything? It's a diagnostic procedure. This is a diagnostic. Range of motion will prevent stiffness. That is why when somebody have weakness, we try to let them move the leg. Therefore, the right answer is C. Make an answer choice that is an intervention. And so that's what we're going to pick. Okay? Number two. And then provide care for a client in refractory asthma. Which prescription the nurse should anticipate? Once again, I'll be teaching you a bunch of content in this question, but that is not the purpose. I just want you to know how to answer questions. If I'm taking these tests, I go back, say which prescription, underlying prescription. Prescription does not means medication. It can be intervention, it can be teaching, it can be anything, right? If you know what refractory is, if you let go of the refractory, then you are in trouble, right? Don't let go of the refractory. There's a reason why I did not say asthma alone. I mean, that is what your board will be doing to you. The test is like, they don't have questions. They will try to trick you a little bit, but you got to hold your stamina and have some way to look at the question and then try to answer it so that you don't get trapped. So once again, if you let go the refractory, you're going to get the answer wrong. Actually, if it's refractory, means you've done everything you've done and it's still not working. This patient is in status asthmaticus. It's the same thing. Refractory asthma is what we call status asthmaticus. That means everything you provided that you use to treat an asthma patient when they come in acutely is not working. Therefore, albuterol is what you use when they come in acutely. You should not give them albuterol anymore, right? Terbutaline is a long-acting. It's not used for acute problem. Neither would you use it in a refractory. Acetylcysteine is mucomist. Asthma patient, if you give them mucomist, they're going to have bronchospasm. So it's contraindicated. You see the answers I've given you. Like I said, I thought about this question. I wrote it. I can write questions for the NCLEX because I know how to think. And this is the way they will give it to you, but you have to go down the line, say, hey, there's a trap there, Abodro. Boom, you pick it, you get it wrong. You pick terbutaline. It's a long acting. You can't use it in acute problem, right? Those are the key. And then you go to B, it's a acetylcysteine, Mecomis. You never touch Mecomis with asthma patient. Magnesium is used for refractory asthma. It can dilate, a bronchodilator, and it will relax the muscle. Explanation there. This is another concept, right? And NS has attended staff education program about heat stroke and exhaustion, like heat stroke and exhaustion. The nurse will select which clinical finding most consistent with heat stroke and exhaustion to indicate correct understanding of the program. Its purpose, there's a purpose of this long question, convoluted to try to trap you. But take your time. Let me show you, right? I want to know correct understanding, right? And we want to learn about heat stroke and exhaustion, right? Which one you should select is most consistent with that. Then you bring your content. You tell yourself, I have heat stroke and exhaustion. What is the difference? You see these three sentences, I have changed it. What is the difference between heat stroke and heat exhaustion? Forget about what I've written, rewrite the question, go for the case, the buzzword, what is being asked, and rewrite the question on your own. He said, now I'm taking in charge. What is the difference between heat stroke and heat exhaustion? That's all. Heat stroke and exhaustion. Then you ask yourself, what is the difference between heat stroke and exhaustion? When you get exposed to heat, you run out, it is too hot, and you start getting sick, you have exhaustion. As soon as you start having neurological problem, you have developed heat stroke. That is the biggest difference between them. Neurological symptoms is number one, and your temperature. So we're going to use that keywords. That's all you need. Don't waste too much time. Go with the content, and then boom. So who, if you have heat stroke or heat exhaustion, who are you going to give a soft drink? Think about it. I told you, stroke means you have neurological problem. Exhaustion, you don't have neurological problem. Who are you going to give what? Soft drinks to? Somebody who has a neurological problem, you should never put anything in their mouth. Therefore, you know this one, you give it to heat exhaustion, right? When you get too much heat exhaustion, usually you'll be sweaty, very profound sweaty. You have diaphoresis. So this is what happened to you. As soon as you develop stroke, you can't sweat anymore. And so your skin become hard and dry. So this is the stroke. I'm giving you the big difference. Neurological symptoms, before you develop that, you have nausea and vomiting. And that is you still having exhaustion. Confusion and lethargy, what does that mean? Neurological symptoms. So you have stroke. The definition of heat stroke, your temperature has to be greater than 104. So that's why you have this. So this is what the table is supposed to look like. If you don't know, then you can take a picture of it, but this is what it looks. That's this single table give you all the difference between heat exhaustion and a heat stroke. Another good for you, you can try this for yourself. A nurse has attended staff education program about diabetic ketoacidosis, which initial arterial blood gas results the nurse should expect after the education. A bunch of information. Don't worry about it. All I'm asking you is, if somebody come in with DKA, what are you going to see? That's all. What blood gas do you see initially when they come in? There is, what are you going to see? You have to think. If they come in, the key word is, what is DKA and what kind of lab work do you expect? So based on what I've told you, what do you think you should expect in this patient? This pH, CO2, and bicam. What kind of lab work? I've given you the answer. D, K, A. That means you have diabetic ketoacidosis. Therefore, test taking strategy. Pick an answer that is an acidosis. Is this an acid? If you pick C, I'm going to be mad at you. You know, it's 7.4. The things say acidosis. Like I say, I'm teaching you test taking strategy. It's DKA. There's nothing there. All that I say is DKA. Therefore, you know it's an acidosis. This 7.4 is not an acidosis. It's a normal pH. pH of 7.5. It's not acidosis, it's alkalosis. So at least you will eliminate a B and C. So we have 50-50 chance now to answer the question. So don't overguess. We're looking for metabolic acidosis. Therefore, which lab work is metabolic acidosis? You know what is going to happen in metabolic acidosis? If it's metabolic, it's going to be what? Bicarbonate. If it's metabolic, it's a bicarbonate problem. Therefore, look at the bicarbonate. I have a video free. I did ABG. It's on the Adapt NCLEX recently. You can check out. And it just like teach you everything you need to know, what you need to pay attention to. So, bicarbonate is bicarbonate problem. If there's acidosis, bicarbonate should be lower, right? And therefore, you know this bicarbonate is normal. Therefore, this is the right answer. Okay, right. Of course, there may be easy questions, but I'll give you hard ones so that when you see easy questions, it become easy, right? And nurse in the emergency department is caring for a client with what? Endocrine, right? I'm trying to hit you there right away. Hyperosmolar hyperglycemic state, which finding the nurse should expect, right? It wasn't intentional because I said, oh, if I give you a DK, you should know something about HHS, right? So I just went there and tried to give you that. The same thing as the strategy we use for DKA, we said what? I have HHS. What am I going to see in HHS? Then spend few seconds to say, what is HHS? The key word is there's no acidosis there. You see, it's hyperosmolar. That means something is too high. What is that? Glucose. And it makes your blood osmotic. And if you make your blood osmotic, you have osmotic diuresis and you pee all yourself up. Because of hyperosmolar, your glucose is so high, you have like profound dehydration because your osmolarity of your blood is so thick, is so viscous from the glucose, such that you have profound dehydration. That's all, but there's no acidosis, right? So what are you going to see in this patient? I've given you the clue. I did not mention one thing, but I've shown you something to tell you this is what your board will tell you. Glucose of 250 is not enough to make a diagnosis of HHS. When you read and you watch these videos, these are the key things you'll be looking for to help you distinguish between these things. Just by giving you a glucose like that is wrong. Like it has to be greater than 600. Therefore, number D is wrong. It's not associated with type 1. Otherwise, you're going to get ketoacidosis. Abdominal pain is classic for DKA. What is the difference between what? HHS and DKA is neurological problem. It's the same thing like, what do they call it? Heat stroke and heat exhaustion, neurological problem. If you forget, come to DKA and what? HHS. The difference between them, there's a profound neurological problem symptoms in HHS. So if there's two people coming and you want to know who is what? HHS, look for neurological symptoms. That is all you need to know. Those are the things you have to know. Look for neurological symptoms and then pay attention to that. Okay, and that will be your right answer. Another one. And this is assessing a client with small bowel obstruction receiving NG tube decompression for 4 days. Which electrolyte abnormality the nurse should expect? Same thing, ABG thinking, right? Break down the question and then figure out, right? And next is assessing the client. I have small bowel obstruction. I have NG2 for 4 days. What would I expect? Guys, think about it. Help me answer this question and help me get it right, right? You got to answer this question. This is not therapy, but it's critical thinking. I've underlined the key words for you: abstraction, and I have NG tube. What I'm going to lead you. What laboratory finding are you going to see? First, you have to know what happened if I put NG tube in you. What electrolyte abnormality is that? This is ABG, but in the different form. Okay, hyponatremia, hypokalemic, hypochloric, metabolic alkalosis. That's what you see. Therefore, don't forget this. I've given you the answer. Now, what is the right answer now? What is the right answer now? So, I see low sodium, this say high, so it's wrong. I see low potassium, this say low, high, it's wrong. I see low chloride, this say high, wrong. When your bicarb is greater than 24, it's metabolic alkalosis. I don't want to give it away, right? I don't want to give it away, but I give you so that you can think about it. If I put metabolic alkalosis, you pick it. To give you, I said bicarb is greater than 24. Like I said, I try to make these my questions in this mini cube and really, really hard that it will frustrate you, but it just make you think, right? So that's the right answer. Okay. Hyponatremic, hypokalemic, hypochloric, metabolic alkalosis. Okay. And let's provide care for a client with what? These are some of the questions I put in my community. So join adapting class. You see the community, I put questions every day, challenging questions, or you can join our YouTube membership. There's three membership. There's a gold, silver, and engine and gold. You get all the videos on my channel. Not every video is available. It's just for the time spent to get this thing done. A little bit of reward, but it's just a little talking. I mean, I don't charge too much. But this is one of the questions at the community page. It's free. You can just subscribe and you go there, you see questions like that. So this question were put over there, right? So I just want to explain it. I get a bunch of email to explain it, right? And next, provide care for a client with Kawasaki disease, right? The next, administer to prescribe Mannitol. What actions by the nurse is a priority, right? I've given you the content for that. And just to help you out, anybody who have Kawasaki, you need Mannitol and immunoglobulin, right? IgG. The question is rewrote. I can rewrite this question and say, this is the same thing as what? Side effect of Mannitol. That's all. That is the test taking strategy I want you to take. Forget about the Kawasaki, even though I put an answer choice there. But the question is not asking you about Kawasaki. Whenever you see a question, they give you the stem and they say you did something for the patient. The next question they're asking you is about the thing you did for the patient. We give the patient Mannitol. You can't tell me they're going to ask about Kawasaki. They have to ask you about the side effect of Mannitol. They're not going to tell you side effect, like I said. I said, what action by the nurse is a priority? Number one side effect of Mannitol, it pull all the fluid from the extremities and it send it to your lung. If the lung is not happy, you're going to have pulmonary edema. So pulmonary edema is number one side effect of Mannitol. Once again, if you don't know, if you give somebody Mannitol, you got to make sure they don't go into pulmonary edema. That is all the question is asking you because it's going to pull all the fluid from the extremities. If you do the same thing for somebody with ICP, it pull all the fluid and then send it to the lung. The lung has to redistribute it, right? And so IM flu vaccine is fine. If you are a Kawasaki patient and we give you immunoglobulin, you can get what? Vaccine that are not live. IM vaccine is not live, but this is not the priority, right? Their urine output is going to increase. It's not a priority because I expect that. If I give you Mannitol, it's like I give you glucose. It's the same thing as I give you a bunch of glucose. It's going to pull fluid, go to your lung, your heart pump it out, and it goes to what? Your kidney, and your kidney get rid of it. So I expect this to happen. I don't know about EKG. You don't need the EKG for that. You're not going to, later on, you're going to heart failure, but mostly what is going to happen is you're going to get pulmonary edema, and that's your right answer. That's what the question is about. And let's provide care for a client on the Med-Surg ward. Which prescription the nurse should prioritize based on the clinical data? So then you click on this. So this is the clinical data. You see a patient with this information. The red does not mean you should focus on it. I just want you to distinguish between the information. So you have a 35-year-old. He has episodic headache, right? And what is he doing? Excessive sweating, right? He has palpitation. His glucose is 210. He has unintentional weight loss, right? High calorie intake, but no weight gain. He eat whatever you want to eat. You go to McDonald's, still not gaining weight. When you check their urine, they have 24-hour methanephrine is elevated. Who can tell me what is wrong with this patient? This is next generation NCLEX. I call it buzzwords. This is adapt NCLEX way, making you focus on the buzzwords if they give you a scenario. This is a diagnosis. Can you diagnose it? Can you, right? 35-year-old, episodic headache, excessive sweating, hypertension, palpitation, hyperglycemia, unintentional weight loss, high calorie intake, but I'm losing weight, and I have elevated 24-hour methanephrine. What is your diagnosis? There's a bunch of trappy answers you will pick, but pay attention. This is all I've given you. Don't bring anything you know. If I want you to focus on something, I'll put it there. This is what you have. If you don't see any data that supports your diagnosis, don't even think about it. Don't only pick one data and use it to make your diagnosis. I call it connect the dot. Adapt and close way. Connect the dot. These buzzwords, let them connect and let them be and basically make a sound in your ear, like making a music. They should give you a musical tone and you can feel it and say, oh, yes, this is the problem. What do you think this problem is? The key word is episodic headache. The headache go back and forth. And then they have sweaty and hypertension. What do you think is the problem? If you know the problem, then you should go and answer the question. So, did you get what it is? It cannot be hypothyroidism. I'm looking at the answers. It can be hypothyroid. There's nothing saying hypothyroid will be gaining weight. So it can't be hypothyroid, right? It cannot be hyperthyroidism because even though you have palpitation, I never give you any other thing. I should have give you a lab work. I said TSH. I never give you anything. So what do you do? This is what we call the 5H, right? I'll give it to you, right? Headache, 1H. Hyperhidrosis, another H. Hypertension, hyperglycemia, right? Hypermetabolic. This is a 5H. Once again, headache, hyperhidrosis. This is hypertension. This is hyperglycemia. And this is hypermetabolism. So that's what the patient has. So now that we know what is the problem, what are you going to do? Which prescription the nurse should prioritize based on the clinical diagnosis? What are you going to give them? What are you going to give them? I said this in my um, um, community page. So, what medication are you going to give this patient? What medication are you going to give it? The key word is they need an alpha blocker. Then you give them a beta blocker. Which of these is an alpha blocker? I'm giving it away. Don't choose A because it's not thyroid problem. So A is gone. Right? TCA, this is TCA. It's bad for this particular problem. If you give them TCA, remember TCA is a monoamine. It's like there's increase in what? Norepinephrine and dopamine. And all these dopamines are monoamines. They will make this problem bad. And beta blocker is not the first choice. So phenoxybenzamine or phentolamine. This one, phentolamine, is another the same thing. Phentolamine or phenoxybenzene, phentolamine. So the right answer is C. So I know you know the diagnosis. I saw a bunch of you people get it. So excellent. You get a diagnosis over there. So excellent. I saw a lot of people get it. So that's the explanation. This is a treatment, is hydration followed by phenoxybenzamine or phentolamine, then beta blocker. Need alpha blocker before a beta blocker. So that's the right answer. Right? Everybody get it. I think I see everybody make the diagnosis. A nurse has attended start of education program about diabetes complication. The nurse should recognize that which of the following findings are commonly associated with diabetic ketoacidosis or HHS. Complete the table below. All you need to do, read it back. The nurse has attended education program about diabetic complication of diabetes, right? The nurse should recognize that which of the following findings are commonly associated with what? DKA and HHS. All I'm saying is, what is the difference between DKA and HHS? When they give you a long question like that, try to simplify it. What is the difference between DKA and HHS? What is the difference? That's all. What is the difference between these two? I talk about it briefly, right? We talk about it briefly. So what is the difference between them? More common in type 2 diabetes. Unfortunately, the software you got to select, not associated, but it's associated with that. Which one has glucose greater than 600? I already told you. I told you earlier on. It has to be HHS. Which one should have ketones? Which one? So both of them cannot have glucose greater than 600. 600 is HHS. DKA usually above 250. It doesn't go close to 600. They will get too sick. Which one is going to have DKA? Ketones is DKA. So this one, no. Which one pH is going to be greater than 7.34? So which one will have pH greater than 7.34? Right? DKA is an acidosis. If it's greater than 7.34, it's usually going to be normal, right? It's going to be normal. So pH, this means the pH is the same as normal. Therefore, it's not this one, it's that one. Which one capillary refill is greater than 4 seconds? Think about it. Which one you're going to have capillary refill greater than 4 seconds? Dehydration. Capillary refill greater than 4 seconds is dehydration. Both of them are going to be dehydrated, right? So both of them are going to be dehydrated. Which one is going to have a map of 50? I'm trying to text your critical thinking. Like I told you, these are questions for thinking, right? Who is going to have a map of 50? Who? Who is going to have map of 50? Remember, map of 50 is the dehydration. You are hypotensive. So both of them will have map of that. Who is going to smell fruity, right? It's going to be DKA, not that one. Who need aggressive IV fluid resuscitation? Who need aggressive fluid resuscitation? We need aggressive fluid resuscitation. Think about it once again. Guys, think, right? You see what I'm trying to get you to know the concept and know how to answer. Use your content. Who is going to have aggressive IV fluid resuscitation? Them is going to have it. And the next one, bicarbonate is less than 18. What does that mean? Interpret it, then find the answer. What does that mean to have bicarbonate of less than 18? Think about it. It means acidosis. Therefore, this is an acidosis and this is not. Who is going to have respiratory alkalosis compensation? I'm just giving you, this is like, this one question, it's basically all the content you know for DKA and HHS. If you have acidosis, you're going to compensate with respiratory alkalosis. Therefore, associated with DKA, this one not associated. This is what is going to be in the table. So if you couldn't get everything, it's okay. But those are the contents I want you to pay attention to, right? But there's key concept you have to know. Raynaud phenomenon. What does that mean? Break it down first. And then you can find the answer. What does that mean to have Raynaud phenomenon? And how do you treat it? If you know the problem, I call it pathophysiology. What is the underlying problem causing Raynaud phenomenon? If you know, target that underlying problem, fix the problem. Raynaud phenomenon is due to what? Vasospasm of the vessel. And so when they're exposed to extreme cold or extreme heat, they have vasospasm and their hands get blue. They get stressed, their hands get blue. They take tobacco, their hands get blue because of inflammation. They take caffeine, their hands get blue. You drink alcohol, their hands get blue. What are you going to do? The word minimize defeat this. They need to stop. Minimize, you need to stop. Minimize, you need to stop. Caffeine, alcohol, and tobacco. And you should avoid stress. So going to the massage unit is the best way to relax yourself so that you don't get recurrent. You tell them to wear gloves, avoid extreme heat or cold, and then completely stop drinking, stop smoking, and stay away from caffeine. Okay? I know a couple of you get it right. Some people, the word minimize, whenever there's something about tobacco, one thing about your test, tobacco, alcohol, caffeine, I call them the cat. I know sometimes I use the expression, but I don't want people to think I don't like animals. Where cats are not great in terms of your taste, right? I call them the cat. Caffeine, alcohol, and tobacco, they are not good things. So you should avoid the cat. And those are that. C, tobacco, alcohol, and caffeine. You should not minimize them. Stay away from them. Always stay away from the cats because they causes vasoconstriction. They causes in terms of Raynaud's phenomenon. The same thing if it's gastroesophageal reflux, avoid the cat. Okay. And next, provide care for a client in second stage of labor requesting pain medication. Which prescription the nurse should question? This require a lot of content. If you understand, if you go to OB, you will know that there's an OB all over it. The key word is second stage of labor, and I need medication. Whenever a lady is in medication, you have to know what to do. When they are in labor, the idea is to provide medication at the peak of contraction. But what medication can you give? Once again, this is one of those questions you should not run away from, right? Second stage of labor. Why did I specifically say second stage? Why did I say second stage of labor? That means there is something there you have to know. Second stage of labor is crucial, right? Because you're about to go into delivery. You're about to deliver the baby right away. So that's very, very important. The key is if you're going to deliver in 4 hours, you should not give them any medication that can affect the baby. Second stage of labor can take up to 2 hours. Local anesthesia doesn't last that long. Epidural usually it takes some time to get it done, but it does not affect the baby. Inhaled anesthesia doesn't do that. This is opioid. IV butorphanol is an opiate that can cross the brain, it can cross the placenta and get to the baby. You have to, because it can last for 4 hours, it can cross and the placenta and affect the baby. So we should not give it to the mommy at this stage. Usually you can give it to them in stage one. But if they're within stage two and then mommy can deliver within 4 hours, you should stay away from this opiate. Nobufium is another one that you should stay away from. But these are all opiate derivatives. You should stay away from that. Okay? So, short explanation. No opiate. And next is assessing a client at 16 weeks of gestation with 3 days of excessive projectile vomiting after sushi dinner. Which of the following the nurse should expect? This is one of the questions I put in the community chat. It's the same thing, I've already explained it. It was the same question about the NG tube. The same idea, but I change it to think about it in form of ABG, right? Next is assessing 16 weeks, you have excessive vomiting. When you have excessive vomiting, okay, it's the same thing like I put NG tube in it. And I told you the problem they're going to have, metabolic alkalosis. Therefore, if they have metabolic alkalosis, what do you want to do? What do you expect? What are you going to see? It's a test-taking strategy. Alkalosis. To control your metabolic acidosis, flip this. You're going to have respiratory acidosis. And use it to answer the question. It's not a difficult question. It's just like thinking about it, right? If I've been vomiting for 3 days, I will be dehydrated, right? And I'm going to have metabolic alkalosis. The patient, in order to control the problem, will have respiratory acidosis. Respiratory rate of 30 is not respiratory acidosis. That's respiratory alkalosis. Therefore, I should not expect this. If I've been vomiting for 3 days, I'll be dehydrated. If I'm dehydrated, my heart rate goes up. I should not expect bradycardia. I have metabolic alkalosis. This is not metabolic alkalosis. 7.34 is almost normal. The patient will be hypoventilating to create respiratory acidosis in order to compensate for the metabolic alkalosis for whatever is going on until it's corrected. So this is what the patient will be seeing in that the nurse will be expecting in that patient. So that's our answer. So that's the explanation here. Any questions, guys? They will not be hyperventilating. There's no way they will try to hyperventilate to compensate for the disease process, what is going on. So hyperventilation. And let's provide care for a client in an outpatient medicine clinic. This is what you have. You have headache, you have sweaty, you have fainting, you spell, you have palpitation during maturation. Symptoms spontaneously resolve after the maturation. No what? New medication. Slightly tachycardic, your blood pressure is high. Rest of your enzymes normal. You have a pulse is like bounding, right? Can you make a diagnosis here again? What is this? Headache, sweaty, fainting spell, and palpitation when I'm having maturation. If you don't know what it means, that means you're voiding, urination. This is what it means. If I try to void, this is what happens. So this is urine. Urination is the same thing. If you don't know, but look at the key things. Headache, sweaty, fainting spell, and palpitation whenever you try to urinate, right? And your pulse is regular. There's normal. Your neck is normal. There's no mass there, right? Can you figure out what is going on with that patient? I've given you the three things about this disease. That is headache, sweaty, fainting spell, palpitation when you have maturation. Is this? It's the same thing we saw, but sometimes you can have it on the bladder. And this is another presentation that can happen. So that's what you can see. So it's the same thing, pheochromocytoma. That's what you see. So what are you going to see? What are you going to tell the patient? Which of the following they should avoid because it can precipitate the same thing. They should avoid banana, cheese, and caffeine. Those are all bad symptoms. Things when you eat it, it can precipitate the same information. So this is the same as pheochromocytoma, that one we saw, right? Which prescription the nurse should prioritize? Now, what are you going to do? The same thing. Do you get a CBC? You get a complete metabolic count? You get liver function or 24-hour urine collection, right? What are you going to do? 24-hour urine collection. Based on what I told you, how will you make the diagnosis? Do 24-hour urine collection? You do 24-hour urine collection. To avoid false positive results of the 24-hour urine collection, which teaching is appropriate? This is a concept you have to know for that particular problem, right? For the fuel, because it's all monoamines. That's the thing, monoamines. Anything that will increase norepinephrine, avoid it. Serotonin, avoid it. Dopamine, avoid it. Epinephrine, avoid it. Norepinephrine, avoid it. So that's the key. So look at the answer choice if you can see if there's anything close to them. If you look at the answer choice and see if there's anything close to them, right? Seleginine, dopaminergic agent, imipramine, methyl-dopa, and buspirone. Which one they should avoid before they do the study? Which one? Which one should they avoid? I can tell you this is dopamine, so it has dopamine in it. If you remember, seleginine is a MOIs. MOIs are norepinephrine, serotonin, and dopamine. They should avoid it. Imipramine is a tricyclic antidepressant. It also increases norepinephrine and dopamine. Methyl-dopa is dopamine. Buspirone also increases norepinephrine and a little bit of serotonin. So all of them, the client should avoid all of them as a before they do the test. So that's that question. So if you don't know, that's another way they can present it to you. You can get it in your bladder. It's adrenal gland problem. And this is assessing a client in endocrine clinic with 3 months of fatigue. TSH is elevated. T3 and T4 is decreased. Which other finding the nurse should expect? Select or apply. Is it difficult? Look at it. Assessing the patient is complaining of fatigue. Your TSH is elevated. Your T3 and T4 is decreased. What do you think? What is your diagnosis? Put it together. T3, T4 decrease, and TSH is increase. And fatigue. What is your diagnosis first? Who can tell me what is the diagnosis? And if you know the diagnosis, you can know what to expect. So, what is the diagnosis for this problem? What is the diagnosis? If you know the answer, type it. Fatigue. What is your diagnosis? Put it together. Fatigue, TSH elevated, T3, T4 decrease. This is what? Hypothyroidism. And I say one word, adapt and increase. If you come to my crash course, you learn a lot. If you need some content, try it. The next one is coming on June 1st. If you don't have money, you can try the on demand. I saw the video for the crash course, but this is the key. Hypothyroidism, I call it, all your symptoms is going to do what, right? All your symptoms is going to go down, right? Except your weight. So it's the only weight that goes up. The rest of your symptoms go down. Constipation feel like it's going down. Weight is not going down, right? It's supposed to go with your weight is supposed to go up. This is going down. I don't want it. Palpitation is going up. I don't want it. Air loss is going down. I like it. Heat intolerance is going up. Except your weight, don't pick anything that goes up, right? Dry skin look like it's going down. So pick those you're confident. You don't have to pick everything. But constipation is consistent with that problem, right? Air loss is consistent with that problem. And dry skin is consistent with that problem. Heat intolerance is consistent with hyperthyroidism. It is consistent with the hyperthyroidism. Palpitation is not. But this is the question to let you think. It's designed to let you think. Okay. So that's the thing. This is hypothyroidism problem, constipation, hair loss, and dry skin. Few more questions than we that. And let's provide care for a client in emergency department with what? Dark amber urine and muscle pain after cocaine use. Creatinine kinase is 15,000. Which action by the nurse is a priority? Think about it. What do you think? Amber urine, muscle pain for cocaine use, and creatinine kinase. If it's a cocaine, probably injected. And now you have creatinine kinase is elevated, 15,000. This may be rhabdomyolysis. Amber urine is consistent with that, and muscle pain. What is your treatment for rhabdomyolysis? What is your priority? You check for myoglobin, you check for start EKG, you infuse fluid, or you give them furosemide. That's what the question is asking. What is the priority for this? You just need to give them fluid. You're going to give them furosemide after the fluid. You're going to get the EKG after that. Myoglobin, another more, you don't even need it because you know what the problem is. CK 15,000, you already make a diagnosis. Patient need fluid resuscitation. That is the test taking strategy to master this question. Okay. Same thing. And then provide care for a client who develops seizure, right? Grand seizure. Don't worry about it. Develop seizure. During morning assessment, the nurse received the following lab report. Which electrolyte the nurse should suspect to be the possible cause? Look at it. Sodium 120, potassium 4.2, BUN 18, creatinine 1.1, calcium 7.2, and magnesium there. Which of these things you think can cause seizures? That's what I want to ask you. That's all. It's fancy question. It's like intimidating. There's nothing. You got to click things, but I'm asking you, what electrolyte problem do you think can cause seizures, right? The sodium is too low, it causes seizures. Potassium was normal, and calcium is too low. Low calcium will make you excitable, right? So you get seizures. Magnesium is normal. BU and creatinine don't cause seizures. So sodium and calcium are your right answer. Calcium is low. which situation as a possible cause of hyperkalemia. So which of these causes hyperkalemia is, that's all. That's what I'm asking you to do, right? Bumetamine is what? This is a loop diuretic. It does not cause hyperkalemia. It causes hypo. Crohn's disease is a adoption problem. It causes hypokalemia. So it does not. Addison, yeah. Addison disease will give you hyperkalemia. Renal failure is the most common cause of that. And acidosis always do that, which is opposite to what? Prolonged NG tube. So NG doesn't do that. And this is, let me explain it to you why acidosis. If your cell is like that and you have acid here, okay, you want to get rid of the acid, you push the acid inside the cell. You got to replace it with potassium. That's why. So you push potassium outside the cell. So your potassium will go high in metabolic acidosis. But test taking strategy, prolonged NG tube is what? Metabolic alkalosis. So you should not do that. So this is the end of it. I was just going to do an hour, so 6 minutes past. And thank you for patronizing. If you like this video, you can subscribe. Like I said, we have a class coming in June 1st.